Okay, so we are going to live stream now onto the YouTube.
Good luck to everybody.
And I will share the link. So I'm going to share it on the our pediatric group as well as that's the on the pediatric group and Sanjay, you can actually now send it to your friends as well. This is all shared now. And let me actually share it on the Facebook group as well so that we can. Yeah. Sorry, guys. The problem with the YouTube thing is that it's difficult to follow the question answers. So I'll try to see if you can actually follow that. But people can actually put questions onto the on the Facebook as well. So I've shared the group now, on the group as well. Shall we start then, Jody?
Yeah, sure.
Yeah, I will 1 second stop sharing my screen. Yeah. Okay, so we on to our 7th symposium, Pediatric Symposium. And today we have 3 topics with pediatric trauma on central venous axis in children and something to do with malignant hyperexia and myopathies. I will hand over to Jody and he will take through this symposium. Over to you, Jody.
Okay, thanks, Shiv. Welcome, listeners. We are on our 7th session of the pediatric anesthesia topic, as Dr. Shokmar Singh mentioned. We're going to have 3 topics for discussion today. The first one will be on the management of pediatric trauma by Dr. Uma Hariharan, followed by vascular access in children by Dr. Sanjay Prabhu. And I will talk at the end about anesthesia in children with undiagnosed myopathy and malignant hyperthermia management. We're going to start with Dr. Uma Hariharan. Dr. Uma Hariharan is an associate professor in anesthesiology at Dr. Rama Logia Hospital at New Delhi. Her specific interests are in the areas of ultrasound-guided regional anesthesia and advanced trauma life support. She's very well qualified to talk about the major considerations in the management of pediatric trauma. So I welcome Dr. Uma to start our talk now, please.
Thank you, sir. Thank you, Shiv sir. Thank you, JD sir. Thank you, Sanjay sir, and everyone else, all the faculty, for this great opportunity and a wonderful topic very close to my heart, that is trauma, especially pediatric trauma. This is a very huge topic, and hence I have tried to cover as much as I can in this short lecture. So if there are any misses and any omissions, kindly look it up, or maybe you can put it in the chat box for further question and answers. So I would be basically talking about the initial assessment and management of pediatric trauma. This is a very important topic because most of the situations we need to understand that children are not just scaled down adults. We need to discuss them as a different entity with separate anatomical, physiological, and emotional differences. And hence, their requirements have to be taken the topmost priority. We need to understand that the ATLS advises the advanced trauma life support. It advises the same sequence of trauma management in all patients, whether it is a pediatric patient, whether it is a geriatric patient, or any adult patient, which starts with primary survey and resuscitation, followed by secondary survey, and finally, if required, transport. The basic motto is to identify and treat the life-threatening injuries then and there before proceeding further with future evaluations and assessments. The child requires constant reassessment, and hence we must not slack down our assessment and our initial assessment and management once we have seen an injured child, because the child may deteriorate later. And one of the most important things which we must understand is that hypothermia is very common in these children, and hence temperature control under all possible circumstances should be done. There should be a trauma team leader, and dedicated pediatric trauma centers are known to produce better outcomes in these situations. The most important thing which must be remembered by all the trauma team leaders is a close loop communication and perfect understanding and definition of laid down roles. After the initial assessment and stabilization, if required, we may be required to transfer these pediatric patients. And there is this template known as ABCS bar, which I will come to later on. There are several causes of pediatric injuries. The most important ones are motor vehicle crashes and road traffic accidents that we come across in a day-to-day basis. But there are several others like drowning, burns, fires, homicides, and fall from height. Accidental fall from height is one of the commonest causes in children, and are responsible for a lot of blunt injury, especially of the brain, and can lead to long-term problems. There is one less explored, or let us say less talked about, of course more talked about in the recent years, form of injury, which is child maltreatment or child abuse, about which I will come to in the end. The following are the three major causes of unsuccessful resuscitation in pediatric injury. Number one, and the most important one, is airway problem. That is the failure to secure a clear airway. Second is the breathing problem. That is failure to support ventilation and oxygenation. And finally, failure to respond to intracranial or intra-abdominal injuries. Now, in pediatrics, the mechanism of injury is equally important. This is a very common, the handlebar injury of children who are riding on the bicycles, wherein this can result in both chest injuries and abdominal injuries, as well as head injuries, as you can clearly see in this picture. And also the lap belt injuries, because when we are traveling in motor vehicle or cars, we may not be very particular about wearing the seat belts, or maybe they are faulty. And if the child is sitting on the front wheel, or maybe besides the driver, there are greater chances of these kind of injuries like vertebral injury, bowel injury, liver lacerations, and all these can be life-threatening. The major differences between the pediatric and the adult population, which define our line of management, are many, but the most salient ones are they have less fat and more elastic connective tissue with a pliable skeleton and widespread impact of force. Now, this impact of force is very important because a small these children, if they have rib fractures or maybe clavicle fractures, we may assume that they have an underlying lung injury, because the transfer of energy and the transfer of these forces is much greater in these children. And because of the pliable skeleton, they are more
prone to injuries. They have a larger body surface area to body mass ratio. And this also is important for understanding that there is greater loss of heat, as well as since the head is larger in size as compared to the rest of the body, we must understand that these children can be prone to head injury as well as difficult airway. Now, one very important thing is the maintenance of the hemodynamics in these children with even severe injury up to a large extent. That is, they maintain a near normal blood pressure even with 30% blood volume loss, which is quite a significant blood volume loss. And hence, we must be very, very careful about assessment of these children, that even subtle changes in heart rate and perfusion status can signal a significant cardiorespiratory failure in children with injury and should not be looked over. And hence, proper assessment and reassessment and continuous and dynamic assessment is what is required in these children. One more important thing is the psychological and emotional disturbances which the child and the family suffers following injury. 25% of children, they are known to suffer post-traumatic stress disorder after road traffic accidents. And hence, we must deal with the child as well as the family in a compassionate manner. The facility which is dealing with these children should be friendly and should display compassion in understanding the needs of the child and the family. I have summarized the differences, the anatomical and the physiological differences, which are important in pediatric trauma in this table. As I told previously, the large head and the occiput can result in positioning difficulties, and hence a shoulder roll is required to be placed, and the head need not be placed in a donut. You need to avoid neck extension in trauma in all circumstances till the time cervical injury is ruled out. And hence, any airway maneuver which involves neck extension should be completely avoided. The child has a larger tongue as compared to the oral cavity, and hence airway obstruction is very, very common because of this tongue falling back and obstructing the airway, especially in an obtunded child. And more importantly, when you try to maneuver the airway with endotracheal intubation or maybe a supraglottic device, because of the huge tongue, you get less room for your airway maneuvers. And another important thing is that these children, the tongue can get swollen, especially in maxillofacial injuries and oral injuries. The tongue and the connective tissues can get swollen very soon and can suddenly cause an airway obstruction and even a difficult airway, which can cause problems to us. These children may have large adenoids and tonsils already pre-existing, which may not be evident in the immediate history taking and may be evident to us when we are doing a laryngoscopy, and hence greater chance of bleeding when we are passing a tube, and hence we need to probably select a smaller size tube and be very gentle in our maneuvers. And in all these situations, better to avoid blind nasotracheal intubations, which can cause trauma. The cricoid is the narrowest part, as is already known, and this can result in difficulty in passage of the endotracheal tube, as subglottis is the narrowest part and very prone to edema. For example, if the child is having any oral injury and you are taking more than 2 or 3 attempts to intubate the child and in the bargain cause some amount of airway injury, these structures can go into edema or inflammation very soon and cause complete loss of airway. This can be very, very disastrous in a trauma situation, and you may not be able to save the child. Hence, we need to be very careful, especially where doing these endotracheal intubations. You have to monitor the cuff pressures, and because of these anatomical differences, it is said that needle cricothyroidotomy is preferable to open cricothyroidotomy in children less than 12 years of age. The lower GE sphincter tone and a larger stomach in comparison to the abdominal contents also cause greater chances of gastric distension. This can lead to vagal stimulation. The stomach can also get distended very easily because of constant air swallowing by an injured child. The injured child is very anxious and hence can swallow large amounts of air. And this can make the child prone to aspiration and as well as gastric distension and vagal stimulation. The anterior larynx and the anterior cords can also cause difficult airway in these children, and the shorter tracheal length can make the child prone to endobronchial or right mainstem intubation during airway maneuvers. This also has to be taken into account, especially when we are fixing the tube, because insertion of a definitive airway, we need to understand that fixation of the tube, a cuffed tube, is very, very important. And we need to fix this in a child so that the bilateral air entry is adequately achieved. Increased vagal response to laryngoscopy and limited respiratory reserves also lead to problems during intubation, and it is better to use advanced airway maneuvers and advanced equipment like video laryngoscope. The initial assessment involves A, B, C, D, E. A is airway with cervical spine control. This is always the priority in all trauma situations, followed by B for breathing. C is circulation and shock management, which is hemorrhage control. And D is disability limitation with head trauma management. And E is exposure or environmental control with hypothermia prevention. So primary survey involves A, B, C, D, E, wherein life-threatening conditions are identified and treated in this prioritized sequence. And then comes the secondary survey, which does not begin until the primary survey is completed and all resuscitative efforts are underway with definite signs of improvement in the child, and the child is then stabilized. Secondary survey begins with history, which is basically the ample history, and then it goes to a head-to-toe evaluation of the child. Primary survey can start even at the injury scene. Now, this is done by the pre-hospital trauma technicians, or pre-hospital personnel who assess the child at the injury site, and then they stabilize the cervical spine, put him on a long spine board, give him 100% oxygen, and do basic maneuvers, and then shift the child to the trauma centers. The aim is, again, as I told you, to ensure a patent airway, adequate breathing, circulation, and assess the neurologic disability with cervical spine control. Now, I would just like to touch upon this very useful thing which we have with us. That is the Broslow's emergency pediatric tape, which is used for assessment of the child's weight as per the height of the child. This is nothing but a long tape, and the child is placed along the length of the tape with head, red side having the head and the heel towards the other end. And the tape that is level with the child's heel will provide his or her approximate weight in kilograms and the color code. So as per the color code, the weight is determined, and hence this helps the emergency physician or the person who is there in the trauma center to give the drugs and take up the airway equipment without wasting time on calculations, because time is of essence. The golden hour in trauma has to be maintained, and hence we cannot, and at the same time, we cannot go wrong in the calculations in a pediatric child because it is weight guided. So we cannot be even approximate regarding the weight. So this gives a reasonably good weight chart and must be available in trauma centers for early identification. Now coming to this bit on cervical spine, it is a big topic in itself. But I would just like to emphasize that cervical spine control goes hand in hand with airway control. Any airway maneuver in which there is neck movement should not be done. And it is important to understand that in children, because children are very unique, they have immature cartilages and the bone growth is still yet to occur. And hence, these spinal cord abnormalities can occur without radiological abnormalities, which is known as skyvora, in nearly up to 30 or to 40% of children. And hence, even if the X-ray may be normal in the initial 24 hours, cannot rule out a cervical spine injury. And hence, this stresses the importance of again and again assessment and reassessment of the child. There are 5 clinical criteria, because this question is being asked by a lot of people. There are 5 clinical criteria for not obtaining a cervical spine X-ray in a child with trauma. These are: a child with no midline cervical tenderness, no focal neurological deficit, no alteration in alertness or mentation, higher mental status, no intoxication, no painful or distracting injury, and there are no evidences of obvious cervical spine injury. 3 different cervical spine X-ray views are commonly ordered: the cross-table lateral view, the anterior-posterior view, and the odontoid open mouth view. I will not go into the details of this because this requires a separate lecture in itself, but cervical spine immobilization need to be done with a rigid cervical collar till it is cleared. Now, just a brief about the X-ray points which we need to understand. There was this Powers ratio. This was what was told to us right from our post-graduation days, that Powers ratio is very, very important. If it is less than or equal to 1, we can be reasonably safe. But there are several other distances which we need to understand. But more importantly and more concisely, PECARN, that is PECARN, the predictors of cervical spine injury in children, Pediatric Emergency Network, has come up with this set of criteria to rule out children with cervical spine injury. If the child is having altered mental status or focal neurological deficit with complaint of neck pain or torticollis or predisposing medical condition, like for example, if the child is having some cervical canal stenosis pre-existing, substantial injury to the torso or maybe to the neck, and if it is a diving accident, now diving accidents are very common with the sports thing coming up, this can, and high risk motor vehicle crash, all these things, the presence of even one or more factors has a 98% chance of cervical spine injury, and hence we need to do a cervical spine X-ray to clear these children. Now there is this nexus criteria, National Emergency X-ray Radiography Utilization Study for again cervical spine injury in children with normal level of alertness, no midline. This was which I had told in the beginning. These children need not have cervical spine X-ray to rule out cervical spine injury. Now coming to airway management as such, I will not be going into the details of airway management. Just suffice it to say that in these children, when we manage the airway, pre-oxygenation, calculation of the endotracheal tube size and depth, avoidance of oral airway, and using a 1-inch pad beneath the torso and avoiding the head so that we do not extend the neck to avoid cervical spine extension, and drug assisted rapid sequence intubation is what is recommended. These children are more prone to bradycardia and hypoxia, and nasotracheal intubation is to be avoided at all costs, especially when we are not aware of the presence of skull fracture, base of skull fracture, maxillofacial injury, or even nasal injury in these children, and sometimes even adenoids which can bleed. And surgical cricothyroidotomy is not indicated in children below 12 years of age because of the anatomical differences, and cervical spine protection has to be given. Now coming to breathing, we must understand that adequate oxygenation and ventilation is the hallmark of saving a child. We must be able to identify pneumothorax, which is hyperresonance on percussion, and hemothorax, which is dullness to percussion. But we must remember that tension pneumothorax is a clinical diagnosis. We should not wait for an X-ray diagnosis for a tension pneumothorax, and hence immediately treat the child with a needle decompression at second intercostal space of the affected hemithorax, followed by chest tube insertion. And during this, we must always monitor the child with pulse oximetry and ETCO2, because pulse oximeter only measures the SpO2 and not the oxygen delivery. And there are higher chances of endotracheal tube displacement in a child as compared to an adult. In circulation, there are several critical points which we must remember. The most important point is these children respond to blood loss pretty late, and they respond with tachycardia and poor skin perfusion signs, which are keys to early recognition. Narrowing of pulse pressure and monitoring of the urine output can be very useful in identification of such children. If the peripheral vascular access is not available, intraosseous needles are very useful in children and must be tried before giving up on your vascular access with in these children. When we are unable to find a cause of bleeding or a cause of shock in these children on the anterior aspect of the chest or abdomen or extremities, sometimes log rolling is performed in these children. Remember that whenever we are moving a child with trauma, please do manual inline immobilization to avoid cervical spine injury. And whenever we are treating these children with blood and blood products, tranexamic acid is coming up in a big way, and it is recommended upfront in a dose of 1 gram over 10 minutes in these children, followed by infusion of 2 milligram per kg per hour. This is just a diagram of the intraosseous needle, which is generally given in the tibial tuberosity. I have shown a diagram of both, and they form a very useful armamentarium for us. This is a table to remember how we can assess blood loss in children and how they are going to react physiologically to blood loss. Now, I remember it like a tennis ball game. 15 love, 30 love, 40 love, and like that, just as a rough guide. But to be more specific, mild, moderate, and severe. Mild is less than 30% blood loss. Moderate is 30 to 45% blood loss, and severe is more than 45% blood loss. The most important thing which is to be understood in this table is that the child is able to maintain its blood pressure till 30 to 45% blood loss. Hypotension is very, very late sign, and we should not be waiting for hypotension to occur, because that will suggest a severe amount of shock and sometimes can even trigger what is known as the lethal triad of shock, metabolic acidosis, and hypothermia, which is irreversible beyond a point, and the child may not be salvaged. And hence, picking up these children very early in their shock is vital to saving the child. And assessment of the CVS, CNS, skin, and urine output, all 4 parameters are responsible for early assessment in shock. Resuscitation, we have the pediatric mass or massive transfusion protocol, wherein after an initial bolus of 20 ml per kg of warm crystalloids, isotonic crystalloids, we are now giving blood products in the dose of 10 to 20 ml per kg of packed red blood cells and 10 to 20 ml per kg of FFPs, along with, as I told you, tranexamic acid. Now, this protocol has come as a damage control protocol or damage control resuscitation to attempt to limit the use of crystalloids in these children. Now, this is nothing but to create a balance so that a normal perfusion pressure or pulse pressure is maintained and hypertension or hyperperfusion is avoided to dislodge, because if you increase the blood pressure beyond a certain point in the face of some uncontrolled hemorrhage or bleeding, the hematoma which may have formed naturally may get dislodged and we may lose the child. The target urine output in all these children need to be maintained between 1 to 2 ml per kg, and there are several preferable sites for venous access. This I already told you, but yes, intraosseous is a big boon to us in children. Now, emergency transfusion or massive hemorrhage protocol can be understood by this algorithm. This is a very, very useful algorithm. What we need to understand is that once we are planning to give the blood products, we must give it in a particular ratio as per the institutional protocol. Here it is given in the ratio of 2:1, 2 units packed blood cells to 1 unit FFPs. And then in children less than 6 months, we need to give irradiated packed red blood cells. Hence, we must have a very good rapport and communication with the blood bank in these children, and trauma centers need to be equipped with blood bank to save these children. And patients at risk for critical or uncontrollable bleeding may be required to give immediate blood transfusion, maybe within 5 to 20 minutes, with even an O negative blood group, if a cross-match blood group is not available, because that will take at least 1 to 2 hours to get the report. And hence, up to 2 units of O negative blood can be given in these children within 5. And of course, tranexamic acid needs to be given, and monitor the urine output and prevent the development of hyperkalemia, hypothermia, and metabolic acidosis in these children. Of course, calcium gluconate also needs to be given in massive transfusion to prevent the development of hypocalcemia. Now, coming to abdominal trauma, PCAN again has this pediatric emergency network, again has the clinical prediction rule to identify children at low risk of intra-abdominal injury, and we may just leave these children with constant observation without proceeding for a CT scan in these children. Those signs are no evidence of abdominal wall trauma, GCS score more than 13, no abdominal tenderness or guarding, no thoracic wall trauma, no complaints of abdominal pain, the breath sounds are normal, the bowel sounds are also there, and vomiting is not there. So in order to reduce the radiation dose in children, because nowadays there is a lot of work coming up which says that the exposure to radiation at a young age causes a child increased risk in the development of cancers in later life. And hence this ALARA principle, as low as reasonably achievable, is used, and fast imaging, that is focused assist sonography in trauma, is highly recommended to avoid radiation exposure. This is extremely useful because it can be done repeatedly and as many times as possible without being invasive. Now, coming to head trauma, head trauma can cause long-term problems and even sudden death if not identified early. Vomiting and amnesia are common in children and may not necessarily be signs of head injury, and hence we must be very, very careful regarding assessment, and prevention of secondary brain injury is equally important. Hence, airway control, breathing control, and circulation control take priority or precedence so that this secondary brain injury is prevented. Early neurological consult and even intracranial pressure monitoring and spinal cord injury has to be limited. The Pediatric Emergency Care Applied Research Network has the head CT algorithm for children more than 2 years and less than 2 years. This algorithm basically says that if the child has a GCS of less than 15 or signs of basilar skull fracture, then you must get a CT scan done. But if these are not present, and the child has symptoms of vomiting, loss of consciousness, headache, or even the mechanism of injury which says that it is a motor vehicle ejection or a fall from height which is more than 5 feet in children more than 2 years and more than 3 feet in children less than 2 years, then again you can consider getting a CT scan done. But if the answer is no to any of these, then you just need to observe and reassess. Now in children less than 2 years, if the child, again, the same thing, most of these are the same criteria, just that the fall height is more than 3 feet, the patient needs to undergo a CT scan. Of course, a parental preference and a joint decision-making needs to be undertaken in these situations. Now, the children also have modified Glasgow Coma Scale. The best verbal response, because these children cannot vocalize and say that, yes, I'm having headache, or I'm having some problem in my foot, or I'm having motor loss or sensory loss. So different scales have been developed in these children, the modified Glasgow Coma Scale. This is all available for you in the internet. But I would like to tell you about this pediatric trauma score. Now, this PTS is very useful in defining children who will need transfer to a pediatric trauma center. This pediatric trauma score is very useful. It assesses several parameters. The most important ones are airway, the systolic blood pressure, the level of consciousness, fractures, especially skull fractures or pelvic fractures, cutaneous injuries. Now, all these parameters are assessed and the scoring is done. After the scoring is done, if the score is less than or equal to 8, it predicts a higher mortality. So if the score is more than or equal to 8, the child requires transfer to a pediatric trauma center. for further assessment and management. Now, there are several scores which have come up in pediatric trauma. One score which is known as the big score. Now, this big score is, again, it predicts mortality in pediatric trauma, and the base deficit, the INR and the GCS is taken into consideration. And if the big score is more than 16, it predicts a very high mortality in these children. I would also like to tell about this pediatric assessment triangle. This I had even read it quite long back, even before the post-graduation days. This is what is generally done in most of the emergency rooms, wherein a tripod of assessment is done quickly within 5 seconds, 5 to 10 seconds. The appearance of the child, the work of breathing, and the circulation to the skin is assessed. And then we will follow the ABCDE protocol in the initial assessment and management after this. Now, coming to the S-bar sequence or the template of assessment for, I'm just going to finish my slide in 2 or 3 more slides. This is very important for transport or transfer of the child to a higher center. S-bar is the template which we generally use for giving over and to document before we transfer the child. A stands for airway, B is for breathing, C is for circulation problems, which we have identified and treated, and what are interventions which we have done in all the 3. And S stands for situation, wherein the patient's name, age, whatever other details, the physician's name, the mode of transfer, the IV access, and other interventions and investigations are mentioned. The background is mentioned, the history is mentioned, the blood products or medications or imaging performed, and splinting. In musculoskeletal injuries, we also apply splints. And these are also mentioned in this because there are very high chances of compartment syndromes during prolonged transfers. For example, the child is having an air transfer or a long road transfer. We all need to give a proper over to prevent further complications in a child. And A stands for assessment, the vital signs just before transferring the child, the pertinent physical examination and treatment signs. And R is the recommendation, what kind of level of care or transport of care or medication intervention is needed in these children. Now, coming to the last of the slides, this is a highly neglected branch of injury in children, the child abuse. There are no proper or stringent laws to identify them, to report them, to bring the persons to book, or to have a proper data regarding the incidence and prevalence of these types of injuries. Hence, they are underreported, and hence this can lead to long-term problems in the child, not only physical injuries, but also mental trauma. It can be both physical, sexual, psychological, emotional, behavioral, and sometimes even neglect of the child can be classified as child abuse. So we have to have stringent laws, and maybe only NGOs are taking up these issues. And I am aware of the AAGBI guidelines on these, which are available on the internet. We all can go through it. The child will generally present as doctor shopping. I mean, the parents will bring the child to different doctors at different ED or maybe the same emergency departments with different kind of injuries in different stages. The bruising may have different colors. There can be green stick fractures, perioral injuries, perianal injuries, and sometimes prolonged interval between injury and presentation to the ED. And the child may have some emotional disturbances as well. So we need to have our tentacles quite high up in suspicion of such injuries, and document them and properly report them, and maybe form a closed group network, institution-based protocol to take care of such children. So repeated traumas, they can present with repeated traumas. I have personally seen a child with cigarette burns. So these kind of injuries are not reported. So hence we need to be doubly careful. So thank you very much for your patient listening. I'm sorry I was a little fast because I had to finish a huge topic in the limited time. But yes, thank you so much, Shiv sir, JD sir, Prabhu sir, and everyone out there listening to this. Thanks a lot. I'll stop
That's
sharing.
really, thanks, Iman. That was really good. Great. I mean, we covered a lot of grounds in the short time, and thank you very much. I'm sure people who are want to listen again, they can go back and listen, and also look at the slides in their own time. And
yes, sir.
And as you mentioned, some of the resources out there are very important, especially in a system where there is not a full setup, in somebody working in remote areas where they, how do they connect the dots in terms of if a suspected child abuse, who are the persons they need to connect to? It's very important. I think the system here usually connects between the law enforcement agencies as well as social workers, as well as the hospital sets up a specific what they call practitioner who specialize in this area, refer to this so that they can do in a non-judgmental way investigate these things, and also alert the social workers and the law enforcement people, again without any judgmental way, so that it's just to rule out at what is paramount is to protect the health of the child, and obviously it has to be done in a very, very sensitive way so that it doesn't offend the parents, because very often some of these injuries, what we think, I mean, sometimes we have to have a heightened suspicion, but sometimes like children's present with multiple fractures could have underlying metabolic diseases like osteogenesis imperfecta. And that has happened as well, where the parents were blamed and the child was snatched away when there was an alternative medical reasons for it. So as a healthcare practitioner, we shouldn't be judgmental, but at the same time, we have to, as you said, heighten awareness about these things, and have a system in place wherever we can, where working, we have to have a system in place where if we identify something, what we do about it. Yeah. Great talk, Umar. Thank you very much. Thanks for
thank you, sir. Thank you.
I think, Jory, it's different in India, where the teachers, the parents are allowed to actually slap children. Be a little bit. I think it's considered as a normal part of upbringing. Not in I think UK and US and some of the Western countries where their safeguarding issues are taken very seriously.
Yeah.
And every hospital actually has got leads for safeguarding for children as well as adults. Actually, it's not only question of children; it's also for adults who have dementia. They're also the safeguarding issues are equally important. I think the talk was like the idea was to actually give a sort of an overview of the trauma in children, which was very well done.
Yes, sir.
I think we should actually share the resources as a separate link for this on the group, so we can actually create a post with different links to where people can actually go through the guidelines or the references to which you've actually talked about.
Yes, sir.
Sanjay, Vikram, Guru, anybody wants to add anything to Sanjay? Do you see any of these in your
mind?
Yeah, I think it's a huge topic. I think she's covered well.
Thank you, sir.
In fact, this requires a separate symposium by itself, I think.
Yes.
Yeah, I think we need to actually also, I think, as we were talking before, sort of have specific areas of like head injury in children.
Yes.
Or cardiac injuries. Vikram, do you see any cardiac trauma in your setup? Or Vikram?
Yeah. Till now, I haven't seen any cardiac trauma as such. But even this, like what Dr. Umar was mentioning about the mistreatment to the kids, and here actually there's laws as well, like even the slightest negligence of the parents. So even the parents and the caretakers are taken to task if there's some negligence towards children, and then they have some falls or
it depends on the sensitivity of the I think the people in the country. Like said, in India, people tolerate that. I mean, Yeah, like it's in the northern side, it said that mother has to have the slipper in there, and if you haven't had that, you have not grown up properly. But I think in the West, probably say that I think we need to be a lot more sensitive to children. So it's a cultural thing as well. But obviously, I think if somebody like is seeing repeated fractures and cigarette butt injuries and things like that, that's obviously not acceptable. And as well as I think sexual abuse occurs even in India and other countries. I think that again
Yes.
is commonly missed out, and that is actually really bad. That is psychologically, I think, causes severe trauma to children.
True, sir. Very
And
true.
despite actually having such safeguarding, in UK, and I think there are still social carers have actually missed out such things. So there have been very high-profile cases. One was actually known as Baby P. If you actually read about it, it's really, really sad story. So, I mean, these are, I think, very sensitive issues. I think we shouldn't be talking too much into this. I think,
Yeah.
Jordi, I think over to you. Yeah.
Yeah. Let me introduce. Thank you very much.
Thank you, sir.
Uma. I'm just going to. Do I have a meeting? Share screen?
You should. Yeah.
Our next talk will be on vascular access, but Dr. Sanjay Prabhu, as many of you have listened to our previous sessions, Sanjay is a regular speaker in our sessions. He's a pediatric anesthesiologist who works at Apollo Children's in Chennai. His special interest includes medical education, pain management, regional anesthesia. We very much look forward to Sanjay's talk on vascular access. One of the most, what our job makes it interesting as well as more challenging is vascular access. Sometimes a 5-minute surgical procedure can take a half-an-hour anesthetic just to get an access. And that makes this job a little more humble. So I'm sure Sanjay will share his insights into how we feel about vascular access in children in itself. Is something that we struggle every day of our work. Thanks, Sanjay. It's over to you.
Thanks, JD, for that nice introduction. Can you view my slide?
Yes, we can.
Right. So as JD quite rightly says, I think this is something which it's a simple topic, compared to what not covered and what JD will be covering. Vascular access is a very simple topic, but can be one of the most frustrating things, particularly at the start of anesthetics, when we can't get a line in and we struggle. Sometimes I've struggled even for an hour to get a line in a small child, and I think people who have faced that situation will know how difficult it can be. So I'll try and cover peripheral cannulation in children, a little bit about central venous access, PICC lines, and intraosseous access. So compared to an adult, one of the main factors which sort of makes children unique is that you cannot expect a child to cooperate. So many times you might have to give them some kind of a pre-medication, or even you might have to induce them with volatile anesthetic before you do the IV induction. So that has some risks in itself. So apart from that, children, they do have a smaller diameter of veins, so you need to be more precise and more skilled in the way you move your hands. And compared to others, the veins are more easily seen than felt. Again, darker color skin can be difficult. And you might have to do it with bad hands because just the veins are quite small. So that's we call that a dimples on knuckles sign. Yeah. So you find the dimples on the knuckles. So generally, when you find that in a small child, they are going to be difficult. Yeah. So there are certain factors which can predict who can be more difficult. So children less than 1 year of age, obese children, former preterm, because they have spent a significant amount of time in the ICU, so they might have used up all the lines, and children with previous chemotherapy, dark skin. So all these can be quite a challenge for the anesthesiologist. And obviously, so you could have someone who's in the first year post-graduation, or someone who's even 2 years post-qualification, and someone who's doing only pediatric anesthesia. So there could be a lot of difference as to who does the IV cavitation in children. So that's a score which was mentioned to predict the ease of venous access in small children. It's called the difficulty in venous access score. So any score more than 2 in this predicts a difficult intubation, and an age less than 1 again is more difficult. So we have various skin preparations to use in children. Generally, we use the 2% chlorhexidine with ethanol. Some people use isopropyl alcohol, the 70% alcohol. But in small children, less than 2 months of age, it's recommended that we avoid the 2% chlorhexidine because it can cause skin absorption and irritation. So I'm sure a lot of anesthetists know about these things. Tapping over the vein causes histamine release and tends to dilate the vein. Try and make the vein dependent, and some local warmth can improve success in venous access. In children who are dehydrated, which often is the case, children coming for anesthesia, or in small children, neonates, you don't see the flashback as quickly as you see in older children or in other patients. So you might have to wait for a few seconds. Or another technique is, as I've shown in this picture, you remove the hub of the end of the needle and fill them with saline. So I've got some saline filled there. So you would see a faster flashback in these situations in these small children. So that can quickly, will alert you to that you're inside the vein. Right, so we often find that non-anesthesiologists tends to prefer the antecubital veins, but traditional teaching anesthesia is start distally and go proximally for obvious reasons, and always try and choose the non-dominant hand. So yeah, this is another thing which I commonly find people doing. So it's easier, it's good to place the cannula in such a way that the tip does not go across a joint. Because again, because of fragile veins, you can easily tissue the vein and cause extravasation in small children. Now, when you're trying to pick a cannula, sometimes in some lines you don't find the gauge mentioned. Like this in this picture on the left side, it's an arterial line. It says 3 French, whereas in the venous cannula we tend to talk about gauge. So 22 gauge, 24 gauge is commonly used. So how do you know what is what? So a common difference between gauge and French. Gauge is normally used for smaller sized cannulas, whereas French is used for catheters, which are longer and can be bigger. But generally 1 French means 3 millimeters, the outer diameter. Yeah, so normally 1 French is usually a 27 gauge needle. And the common things which we can refer to is a 20 gauge cannula will be equal to a 3 French needle, a 3 French catheter. So what size will you pick? Obviously, you pick the size which is appropriate for the child and the vein, and tend to reserve the larger veins for emergency. And yeah, so they recommend that the catheter to vein ratio is normally 50% in pediatrics and 33% in neonates. This is to prevent thrombosis. So when you have difficulty in getting a venous access, there are certain devices which can be used to help you get the vein quicker. So one is called a trans illuminator. Then you have this infrared devices which I have not used, and the third thing is ultrasound, which most of you will be familiar with. So that is a trans illuminator. So this particularly helps in children who are obese or who have dark skin. So here in this on the right side, you could see that with a trans illuminated hand, you could see the veins. Not as clear in this picture, but generally. In some situations, this device really does get the vein. So I would call this an IV bundle, IV induction bundle, because generally children, if you want to cannulate a 7-year-old child for IV access, they might cooperate, but there are certain things which you can do to make it more pleasant for the child. So one is you could try a sedative pre-medication. Always apply a local anesthetic cream, the EMLA cream, which will help cause numbness, and that's number two. You can distract them by playing a device, talking to them, playing a video from the mobile phone, and so on. Parental presence, again, this can be a double-edged sword. Sometimes if you find a parent who is very anxious, don't have them. Or if you are very anxious, don't have a parent. On the other hand, if you think a parental presence will help the child cooperate, have them with you. And that is a site which you can look for in some situations. But again, the cannulation in this place can be painful, and generally the veins are smaller. So, but again, this can help in situations where you have a dehydrated child. You're trying to find a vein, you can't find a vein in the usual sites you look for. So when you can't find a vein in the normal situations like dorsum of hand, dorsum of foot, the other things which you should be looking for is the great saphenous vein. So in children, generally, if you see pediatric anesthetists, if they can't get a vein anywhere, the commonest vein they would go blindly is the great saphenous vein. The reason being that the great saphenous vein is the vein which is the most constant in location. So it is situated at the medial malleolus. So it's even if you can cannulate it, even if you try a blind insertion, you might hit the vein. So that's the first thing you should be trying for in someone who is where you are struggling to find a vein. Other situations can be the EJV, anterior aspect of the wrist, as displayed here, and the scalp veins. So that's the great saphenous vein displayed there. So you could either cannulate it near the ankle, or in situations which many pediatric many adult anesthetists may not be aware is this particular site. So this is generally done better with a transcylinder with you. Otherwise, it's sort of quite a deeper vein. You may not be able to cannulate it by palpating or by visualizing it. External jugular vein, again, it's a useful option to go for. The thing you have to remember is if you extravasate here, there is a potential for respiratory compromise, particularly in a small child with a short neck. So just be aware of that. Scalp vein cannulation is generally done for children less than 6 months of age, when other veins are not easily cannulatable. So the main risks is, if you look at this picture here, every scalp vein is usually accompanied by an artery. So obviously there is a potential for arterial cannulation with its inherent risks. And the second is you could cause dural sinus thrombosis because these veins communicate into the intracranial dural sinuses. So you could cause the thrombosis of the dural sinus or an infection there. So just be careful. So generally these are sort of temporary measures. We don't keep a scalp vein for long. And generally when you're struggling for vein, don't keep trying. Okay, it's always good to have a fresh pair of hands when you're struggling. This applies to any situation or any crisis situation. There are certain sites where you're more likely to hit an artery. So the scalp, which I had mentioned, antecubital fossa, and third is the anatomical snuff box, where you could potentially cannulate the radial artery. And always try and splint the axis in small children. Now there are different kinds of cannula we have. So one is the normal cannula Venflon, and the other one is it's the pro safety where you don't there's a risk of sharp injury is almost nil. And here again you can see a 24 gauge cannula. Here you don't have a port at the top to inject. Here you have a port at the top to inject. So that's an extra advantage we have. Now, so when you're not able to cannulate someone, obviously call for help. Use devices which can help you secure the access. But if you're in a situation like Uma had mentioned, a trauma patient, you're struggling for access, patient is exsanguinating, the quickest would be a intraosseous access. So this is a life-saving intervention which all of us need to be aware as to how to do it. So it's similar to establishing an intravenous access either through a peripheral line or through a central line, and all the drugs which can be given IV can also be given intraosseous. And generally the veins here they do not collapse even in shock. That's why I think in a patient with shock, this is a useful device to useful technique to learn. And the sites which generally we go to is around the knee. So we start at the tibia, upper end of tibia normally, and the other sites as mentioned there. Now, the picture on the right top corner, that is available in India. It is a powered gun, basically. It's available from Arrow. This device costs 17,000. So it's quite affordable. In fact, I have bought this device on my own. And the needle which comes along with it, that costs around 5,000. But I think it's still worth having in your emergency, particularly if you're doing a lot of children. Now, this is a common question which can get asked in the exam. So if you have a 6-year-old patient coming with trauma, with splenic laceration, the patient is bleeding quite significantly, which line would you choose, a central line or a peripheral axis, given that both have the same internal diameter? So I've found a lot of trainees answering this as central line, but no, when you have a patient who's bleeding, a peripheral axis is better because of this particular formula, because the length of a peripheral line is inversely related to the flow as per the Hagen-Poiseuille's formula. So we go for the peripheral axis. Now, briefly about the central venous axis. We have various kinds of axis for central venous insertion. So the traditional catheters, which we normally use for central lines, the double or the triple lumen lines. Then for long term, we have things like the Broviac and Hickman lines, which are usually tunneled. Then for chemotherapy, we have the sports. And finally, we have the PICC lines, which is again done by anesthetists. The other two are usually done by surgeons. So what size central line would you use? Again, try to pick the size based on the age and weight of the child, and try to minimize the number of lumens. So for a child weighing less than 10 kilos, usually it's 4 to 4.5 French, 6 centimeters. For an older child, it's usually 5 to 5.5 French and 8 centimeters. And anyone more than 40, it will be like an adult central venous catheter. So techniques which can help to improve your success is head down, obviously, a Valsalva maneuver, and pressure on the liver to dilate the vein. And people who do cardiac anesthesia, pediatric cardiac anesthesia, they will know this. In cyanotic children, you cannot make out whether you've cannulated the vein or the artery based on the color. So you might have to attach a transducer to find the pressure to confirm that you're inside the vein and not inside the artery. When you cannulate a small child, unlike others, many times what happens is we try and when we insert the needle, we don't aspirate any blood. So we might usually tend to go, and then as we come out, we slowly aspirate. So we're more likely to get blood on the way out. So because the vein can easily collapse even with the slightest pressure. So that makes it mandatory that for small children, ultrasound is very important for the various reasons. And we can identify abnormal anatomy or even a thrombus sitting in a vein. Now, this slide I've mentioned mainly, I'm sure all of you know about the short axis and long axis, but there is this new technique called the oblique axis. There was an article in the British Journal of Anesthesia mentioning about why an oblique axis can be more beneficial compared to the short axis and long axis, particularly in small children. So I would recommend that you read this article to get more out of it. So basically they say is when you do an oblique axis, you combine the advantages of both the short axis and the long axis technique. So that's pictures of the short axis, which we all know. Here in the short axis, you can see the artery and the vein, but you cannot see the tip of the needle, nor can you see the guide wire that easily. Whereas in the long axis, you can see the entire course of the needle and the guide wire. In oblique axis, you can sort of see both actually. So it's something worth trying. Unless you try, you will not know. So just read about it, and I would recommend that you try it. Now we know various techniques, various sites where we can do central line. Traditional would be the internal jugular, the subclavian, and the femoral vein. But this cannulation of the brachiocephalic vein has been sort of talked about in recent times, and I wouldn't say I'm experienced in this technique, but I've tried this in 2 children. It seems doable, and I would again recommend that people who practice pediatric anesthesia on a regular basis try this technique. So basically, what we do is we scan the internal jugular vein in the neck. And as we come down, at one point, you would see the internal jugular vein joins the subclavian vein. That's the onset of the brachiocephalic vein. So on the right side, you can see the X-ray on the ultrasound image here. So the needle is sort of coming at the junction of the IJV and the subclavian vein and entering the brachiocephalic vein. So this is a technique which will be useful in certain situations. And you could see the entire course of the needle in the brachiocephalic vein. And compared to the right side and the left side, the left brachiocephalic vein is preferred because, as you see in this picture, it is longer compared to the right side. Again, I'm sure a lot of people know about this, but whenever you transfuse blood into a central line in a small child, particularly a neonate, you could cause cardiac arrhythmias and even a cardiac arrest because the temperature and the high potassium content, particularly if the blood is old, can cause problems. So just be aware of that fact. Again, you could have variations in anatomy, and generally in adults, you have the femoral artery and vein separated or sort of medial and lateral, whereas in a small child, you could have the artery above the vein. So just be aware of it. So that's why an ultrasound is usually the mandatory when you use it for a small child. Now, tunnel catheters is generally done for long-term access, people requiring antibiotics for more than 4 weeks. We have two types, the Broviac and Hickman. So Broviac is basically a smaller French, and Hickman is for a larger French. Port is basically for chemotherapy patients. So here, as you can see, you have a silicone top with a port, which is generally implanted under the skin, and the medications are given by injecting into this silicone top with a special needle, which also has a Huber point needle. So that's a port. You can see that the device is in the left side under the clavicle. Now, we tend to reserve using this device for any surgery where there is going to be a potential massive blood loss. This is called the Swan sheath. Basically, this was used earlier to insert a Swan-Ganz catheter. So again, it's worthwhile sort of knowing that this device is available, and it's available in a large French. So you can easily transfuse significant volumes of blood very quickly. Quick lines, again, we as anesthetists get called to do these lines. So they are generally done in children who require a line for more than a couple of weeks, and in children whom the venous access, peripheral access can be difficult. So they come in different sizes, the 3, 4, and 5 French. And generally the PICC lines are done either in the cephalic or the basilic vein, but basilic vein is safer because cephalic vein has a high risk of thrombosis. And generally the target area is in the mid-arm region as displayed in this picture, not close to the axilla, not close to the elbow, somewhere in the middle of the arm. Now, again, this is a common question which gets asked. And once we insert the line, we need to know where the tip should be, because that can cause certain issues. So for a short-term line, like a traditional central venous line, it should be at just above the level of the carina. Whereas for a long-term one, it can be at the cavo-atrial junction or even inside the atrium, as in dialysis catheters. Okay, so that's a short-term catheter. So in this picture, you can see the catheter tip is here, and that is the carina. Okay, so that's the carina. The catheter tip is here, which means the position is okay. For a long-term catheter, so here you have the PICC line going from there. It's at there, so it is inside the cardiac shadow. So basically, it's at the cavo-atrial junction, which is below the carina. So, so looking at this picture, for a short-term catheters like we use for perioperatively, the catheter tip should be at or above the level of carina, whereas for long-term, it should be below the level of carina. Now, this line is not in the right position, because if you see at the tip of the catheter, it is horizontally placed. So ideally, when you position the tip of the catheter, it should be vertically placed. A horizontal catheter, particularly when it's infused with hypertonic solutions, it could perforate the vessel wall. So make sure that the catheter is sort of vertical in position instead of being horizontal. This is going to be abutting the vein wall with the potential for perforation. And a femoral venous catheter, again, the risk of thrombosis is highest at the tip of the catheter. So it is recommended that does not lie at the level of the renal veins, because it could cause renal vein thrombosis, which is usually at the level of L2. So it could be below the L2 or above the L2, but not at the level of L2. So last one is in neonates coming for surgery, sometimes they come with what is called a umbilical venous axis. So that's the umbilical vein. We generally have two umbilical arteries and one umbilical vein. So yeah, so when you put an umbilical catheter, it comes and it rests. It should ideally be resting above the level of the diaphragm. So that's the IVC there. So that's the umbilical vein. We have the right portal vein, left portal vein. That is the ductus venosus, and eventually joins the IVC. So the umbilical vein tends to bypass the liver. It is usually used for up to 7 to 10 days, and generally for neonatal surgery. It can be used for neonatal resuscitation. A 3 French or a 5 French catheter is used, and the distal tip should normally lie within the IVC, but above the level of the ductus venosus to prevent thrombosis of the portal or the ductal venous system. So in summary, so vascular access can be quite a simple technique in most children, but in a few it can be quite challenging, and it's probably one of the most I mean, the technique which children fear the most. So you have to take a lot of precautions to make sure it is nice and pleasant, and try to minimize the number of attempts, particularly in a awake patient or in a child who is likely to cooperate, and get senior help if you're not able to get it in 1 or maximum 2 attempts. Intraosseous technique is worthwhile to know, and it's worthwhile to have the device in your OAS, particularly if you're doing pediatric cases on a regular basis. A swan sheath is worthwhile to have, particularly when you're anticipating major blood loss. And some newer techniques to try in your institution would be the brachiocephalic vein cannulation and the oblique axis view for ultrasound guided vein cannulation. This website is good, particularly the pictures which I displayed, the X-ray pictures. I did it from this website, so it's worthwhile going through this website. They have some wonderful X-rays. Thank you, and thanks JD and Shiv for giving me a chance to talk, and be open for questions.
Thanks, Sanjay. That was brilliant, as always. We learned a lot through your pointed explanations and precise presentation. I mean, it's very, very eye-opening too. A lot of things I learned today, definitely. Thank you very much. We'll look forward to questions from the panelists.
Yes, Sanjay, I think we could have mentioned a little bit about, I think, preparation of the children, the skin, and like using amla cream or Prelican, isn't it? So just skin preparation, I think, especially for, I think, collective cases. Kids do fear needle. I mean, all kids, even adults fear needle. Not only children.
Yes.
That do actually make a difference, I think.
Yes, Sanjay did mention about using amla specifically. Yeah.
In the IV induction bundle, I just mentioned briefly.
Okay. I must have missed that. Yeah. And the brachiocephalic approach, I actually saw this been used in adults a long time ago. And it was in the cardiac center, our cardiac center at Liverpool. They used to use, and they use, it's basically going just at the junction of the subclavian and internal jugular, 45 degrees in that. And they used to use 10 centimeter catheter. Well, they're 12 centimeters. They used to call it 10 centimeters, but these are 12, and just put whole thing in adults. So it's a known technique. I think with ultrasound, it probably becomes easier, but it's a known technique here.
Because I remember working with, the person I learned it from is Dr. Glenn Russell. So
Yeah.
he mentioned it as supraclavicular approaches of claving.
That's right. That's right. Yeah. Well, it's basically brachycephalic approach.
Yeah. So this is slightly more major than that one. So that's why.
Is it? Yeah. Okay. Yeah. But again, I think even in adults, that technique is. I haven't seen anybody else use it other than the cardiac surgeons. And I think it was. I think people fear it because they say, "Oh, maybe the lungs is very close by cupula and stuff like." But I've never seen a. But saying that in cardiac surgery you're opening the chest, so pneumothorax is not much of an issue there. But in adults where you're not going to open the chest, I think people will fear that approach. Too low for them. Oblique view, I think that's again, I think slightly new. I don't know how much useful that is actually, because even with oblique view, you're not going to get that cross-sectional, however oblique you're not going to get that kind of thing. So it's almost like actually doing inline approach.
Yeah, I haven't tried it, Shiv. I just read about it and I thought it was mentioned.
Yeah.
If anyone has done that, they could sort of give their review.
Yeah. I mean, the probe footprint is actually pretty large, even in adults. I mean, I do my central venous axis inline, all of them. And sometimes it is difficult, but now we are getting actually small footprint probes now, high frequency ones. So they are very useful. I think children, they anyway use hockey stick probes for this kind of, so probably it's easier with them, but even in adults, it's not the easiest to do inline. Most people actually don't like doing inline. Most will go for. And that's where they suffer. They have seen actually, you will actually have a good size vein proximally, but then as they are going in and they find a thrombus and they say, oh, you couldn't put a guide wire in. You do an inline approach, you find big thrombus. Especially in patients who have been in the ITU before or patients who have had long-term catheters like for dialysis, you invariably find thrombus in the veins.
Vikram must be an expert in pediatrics.
Yeah, Vikram, absolutely. Vikram, many experience.
Yeah, Dr. Sanjay sir has explained, done a wonderful crisp class and he's explained most of the things. So just this thing, like in cardiac surgery, most of these VSD patients, like not the cyanotic. Cyanotics are usually, they don't suffer hypoxia or they don't have arrest during the situation. But a simple case like a VSD, which everybody thinks is just a VSD. But these VSD cases are really chubby cases. So since anyways we are in cardiac, it's a little slightly different since we are going to anyways be putting all the central and arterial lines. So I have a very low threshold of putting a central line straight away because VSD we try once, probably couple of times maximum, straight away induce with CO 8% and put in a tube, and then IJV goes in straight away with the cannula in. So that is, I have very low threshold for those kind of patients. But one more practical approach of these, even with ultrasound hockey stick or even the blind technique, what I need to tell is the practical approach of needle versus a cannula. See, when the cannula is used, it's the whole circle. So if the cannula is in, it's mostly inside, whether you use a transfixation technique or any other technique, it's in the lumen. But if you use a needle, there's a bevel. So usually what people suffer is, experience problems is they get a flash and they say they are able to aspirate blood as well, but the guide wire doesn't thread in. That's the most common. And then and they're so happy getting that flash and they just thread it fast. So if you need to be very gentle while threading the guide wire, and you should not, otherwise you will injure the vessel. So that's regarding the guide wire. But it's better that people switch over to cannula, especially in the neonates, since the whole lumen is inside compared to a needle. So that's what I've changed to techniques when I've moved from needles to cannula in the neonates as well, and even in fact most of the pediatric patients. So that's regarding that. And I use both landmark blind technique and ultrasound, since we go into charity missions where we don't have ultrasound. So yes, and there's a learning curve from somebody who's moving from a landmark technique to ultrasound. And especially in neonates with the hockey stick probe, even the slight movement occludes the lumen straight away. So that technique of holding the probe hockey stick and then you going, and so even this inline technique, again, from moving from out of plane to in plane, again, that also requires some, there's a learning curve for that. So it's slightly different from a pediatric to a neonate straight away. So yeah, that the pressure you put on the hockey stick probe and then how you release it, that's very important. And yes, cannula definitely makes a difference. So try to switch over from needle to a cannula. That's regarding that. And yeah, and the infrared I have not used, like as you told, I have not seen what it is. And trans illumination, the illumination, yes, it definitely helps us, but the depth we will not be able to make out. We can make out the veins, but the depth of the veins, it's difficult to make out to that. But it definitely assesses what kind of veins and what is the technique. And the scalp vein and the great saphenous vein helps us in most of the patients. I mean, that will, yeah, you covered most of the things there. Yeah.
Vikram, can I ask your views on something? Have you ever had a guide wire knot under the skin? Knotting of the guide wire, have you ever had that situation?
Recently we had in a cardiac cath lab, but that was because of the cath technique. I mean, we were going to do a coarctation of aorta, ballooning of the coarc segment. So that became 2 parts, and we had to rush into cardiac surgery with but yeah, no, for the essentially for a central line, no, we never had that. In adult patients, we've had a guide wire slipping into this thing because IIP was concurrently running. So when we put in a guide wire in a concurrent vessel, be in a femoral artery or a vein, especially in a femoral artery, you're trying to put in another artery, and with the IBP running in, it gets sucked in. So you need to stop the IBP in that amount of time. So I've seen personally two chances of that, and in adult patients, but pediatrics we've not had all those things as of now. Yeah.
And Vikram, one more thing. What are your views about when we're not able to thread the guide wire through the J wire tip? Would you reverse it and try and insert it?
Yes. So I forgot to mention this. Yeah. Since when you're using the cannula, so there is a valve there, whether you use a 22 gauge or 22 gauge, when you're using it, especially in more than 5 kgs, there's a valve. So we don't use a J tip. We use a dilator, and the J tip is in the dilator. So that when you put in a cannula, when you take out the needle, the guide wire, the dilator goes in, so that you are occluding the what is it, the valve, the valve. So you are bypassing the valve, and your J tip is inside the dilator. Yeah, so that is how you negate that valve in the cannula. That's how you do it. And less than 3 kgs, yes, when we use this 24 gauge cannula, we put in a straight wire. We don't use a J tip wire in right internal jugular. So that's what it is.
The interventional people call this a cheater. So it's like you put basically it's like a conical small length thing through which you put the J wire so that it's straight and go into it. And it comes, I think with the adult, it's part of the, the guide wire. It comes in along with the guide wire.
No, even in pediatric, it comes to the guide wire, but then you have to negate that valve when you're using the cannula.
Yeah. The adult kits also come with a cannula and things, and I use the cannula, and I teach the juniors to do, because they are used to using a needle. But that's, I think, has come from the way people actually have developed their skills. So if you're using a blind technique, I think it's easier to actually do it with the needle. That's why they feel it. But people feel it. I said, you have been placing the IV cannulas all the time. It's similar to that. It's just that now you're doing under ultrasound. But once the cannula is in, then there's no chance of actually, countering when no counterpuncture don't happen with catheters, the part of the cannula. So I think it's a good technique to actually teach.
I have a clinical question to Sanjay. So a 2-year-old who is coming for an urgent laparotomy, who has got a difficult IV access, and the IV fell out on the way to the operating room. How are you going to induce this child?
Yeah, I would still secure IV access before I induce the child. So is the child difficult or?
It's a very extremely difficult. And then they had an IV in place, a 24 gauge, and you thought you could just get through this in induction and then secure a bigger line with an ultrasound. Now the child is in distress, needs a rapid sequence. And it's a common, I mean, it's we all face it, right? Like it's one of those things. So what's your thoughts?
Yeah, I mean, that's going to be a challenge. So definitely I'll have 2 anesthetists at induction. Okay.
Yeah.
Since I work in a pediatric hospital,
you have the luxury, yes.
I have 2 pediatric anesthetists. In fact, we did have a situation like this for a neurosurgery patient. We have injected the drugs, okay, generally, and finally we find that the line is tissued actually, but the mother line is already in. Yeah. So we just, and he was going for bradycardia, so we had to intubate him. And I quickly did a femoral venous access. I mean, it's without any IV access, we just intubated the child. And once intubated, we just took a femoral venous access. So,
what's your thought on, IM ketamine sucks get intubated? And then...
IM and ketamine sucks for intubation.
Yeah.
It can, I mean, I've not used IM sucks so far ever for intubation, but you could sort of intubate someone with a deep volatile and then secure an access, or get an IO access and then change to once you induce the child.
Yeah. Sometimes you have to, I mean, there's no perfect answer, is it, right? When you're facing these situations, deep volatile on a patient who is, like a high degree of GI obstruction and risk of aspiration, against upset child and difficult access, and how quickly you can secure an access against femoral line, against IM ketamine sucks. Sort of, I mean, I've resorted to, there were like 2 other occasions, similar setup, where, okay, this is known difficult IV access. There's a kid with a gastroschisis who was on TP independent liver failure, now coming for another, like a gut failure and obstructed. They want to re-explore and fall IV access. So we just went with the IM ketamine sucks, at least the separation from the parent, because the kid was like 3 years old. The separation is going to be a challenge, and getting him to breathe a 3/8% SIVO would be a challenge, and the risk of aspiration. So we just, as soon as the kid is softer, the ketamine, I mean, by then the sucks is already working anyway, 60 seconds, and just get with the intubate and then secure your access. I mean, there's no perfect answer. It's saying one of those things we need to face.
So why not just actually ketamine small dose and
and then try for an access,
and then separation. And
then could be tried too. Yeah.
Especially like for example, Sanjay's case, if the patient is a neurosurgical patient, don't know, maybe you were obviously low dose ketamine is fine for ICP, but maybe giving an induction dose IM, even I don't know how successful that is. I think remember at AIMS, that was a common technique where the child came to the gate with the parent, and we went with a ketamine syringe with mixed with atropine and went in the back, and gorilla technique that was taught by Dr. Pawar. I mean, we all did it so many times, and then we would carry the kid.
That's our separation technique, right? Yeah.
I think because the parents weren't allowed into the theaters, I think they were allowed till the gate. So it was a common technique used in, I think, at AIMS. But in UK and I think other places where parents are allowed into theater, then we do induction, I think, in parents' lab or things. I mean, Sanjay has got that experience at Alder.
An alternative to IM ketamine would be nasal dexmedetomidine, which we have tried on a few occasions. 2 mics per kg. Within 15 minutes, the child is sedated. So you just take that.
And they talk about bradycardia and stuff with do you get with nasal at all?
No, no. I mean,
No, you don't get, as in children already have a high.
generally we don't get. I mean, you need to be monitoring the heart rate, but
Yeah.
talking about the bradycardia. I mean, it's to a low rate, but not bad enough that you have.
Yeah, not as much in children who already have a higher heart rate, probably. Maybe in adults, maybe.
Yeah, it's not a. You don't need to pre-treat it.
So is it like you moved over from midazolam to dexmedetomidine now?
I mean, we still use pedicloral as a common technique, but we do use dexmed in some situations where we don't anticipate the child will be very anxious. And once they come to the ward, they become really anxious. So maybe dexmed will help, definitely help.
Interesting.
Yeah, I think midazolam is still a better drug compared to dexmedetomidine because it is dexmed can be unpredictable and it can take a longer onset time. The few situation I've used is more of like obese children and uncooperative or who are autistic, and where your IM where the only way to get this child into the operating room maybe an IM ketamine. Extreme cases, but getting an IM ketamine of sufficient volume into the kid itself is traumatic both for the provider as well as for the child. So I have used that as like a two-step process where you can safely administer intranasal dexmed and give that to work for maybe 15, 20 minutes or 30 minutes. And then the child is sort of a little mellowed. Now you can safely approach the child and administer IM ketamine. Even a smaller dose, rather than the 5 per kilo, you can cut down your dose to 2 per kilo, and then it will be safer to take the patient inside.
The midazolam which you have, the JD, is it oral or nasal midazolam?
We have the IV preparation, which comes as a 5 milligram per cc per ml, and it is bitter. We usually mix it with either some apple juice or with sometimes we mix it with the Tylenol comes in grape flavor, the acetaminophen comes in a grape flavor or cherry flavor. We can mix it with the acetaminophen, or the pharmacy makes in chocolatey midazolam preparation, but they still use the IV preparation to make the oral preparation. There is no specific oral preparation in itself. It's just a IV preparation mixed with the chocolatey syrup made into an oral preparation. So those are some options, or with some ginger ale, apple juice, ginger ale mixed with some midazolam. Keep the volume smaller. I specifically, especially 2 or 3-year-old kid, I would say ask them to take it as one big shot, because once they taste it, they will not like it. So ask them to, and I keep them a little bit of a clear apple juice, saying that this is a clear apple juice. I mean, we can't lie to the kids, right? Like they know the thing. So this is clear apple juice. Your treat is you take this one, a big shot, and then you can mask it at the aftertaste with some clear apple juice. So.
I've tried a combination of oral clonidine and ketamine. Clonidine 2 mics per kg and ketamine 4 mics per kg mixed with honey or sugar syrup. And for small children, in 20 minutes they go sedated.
Yeah, nice. Yeah, we sometimes think too much about the NPO and sort of avoid mixing with something sweetness that can be more palatable for the children and get them through this phase. Yeah. Okay, I think we should move on to our next talk.
Absolutely.
I'm going to share my screen.
You want to introduce yourself?
Yeah, sure. Okay, next.
Yeah, we are.
Okay, is the screen visible without any
Yeah, everything's fine.
Okay. Thanks. Thanks, Shiv, for giving us an opportunity to present some of our topics. I'm Ilava J.D. Srinivasan, one of the staff anesthesiologists here at the Hospital 6 in Toronto. I'm going to talk about in the next 20-25 minutes about some of the challenges in children with the neuromuscular diseases who come present for anesthesia. So these are my objectives. We will cover some of the pathophysiology of the common myopathies. You should be able to describe at the end of this presentation some of the key anesthetic considerations, and also have some idea how to provide a safe anesthetic when a child presents with, especially a hypotonic child presents for an investigative procedure or for a surgical procedure where you're not sure about what is the underlying diagnosis, or when your procedure itself is part of the diagnostic workup, and you are obligated to provide an anesthetic using the very limited information that could be available. So practicing pediatric anesthesiologist, this will not be an uncommon situation. A hypotonic child posted for a muscle biopsy as part of the workup. So we can consider about a 5-week-old who was born full term, admitted for poor weight gain. And you see the child is hypotonic. They did some blood work. They found it's a metabolic acidosis, basics of -10, lactate of 12. Now we are facing, okay, what is this? What are the possibilities of these of the diagnosis? So when you look at the literature on the causes of hypertonia, you're going to find it's probably like maybe 100 to 200 causes of hypertonia. The cause could be central, like children presenting with Prader-Willi disease, adrenoleukodystrophy. The cause could be on the motor neurons, like a spinal muscular atrophies. The cause could be in the muscle itself or in the neuromuscular junction. Today, for the purpose of this talk, we're going to restrict to talk about the neuromuscular causes. So we're going to talk about the muscular dystrophies and some metabolic myopathies. So those are the 4 conditions I want to cover in the next 15 minutes or so. So muscular dystrophy, where the problem lies within the muscle fiber. Then there could be mitochondrial problems or myotonias, and then some channel problems. So I'm going to start with to talk about the Duchenne muscular dystrophy. So this is an X-linked recessive inherited disorder, which means that the mothers are carriers of the disease, and there is a 50% chance that the male child could be affected. If we look at the incidence, it's probably 1 in 3,500 live births. When you look at the pathophysiology of the disease, there is a marked abnormal absence in dystrophin. Dystrophin is a protein that is necessary to stabilize and link the myofibrils to the cytoskeleton. And this dystrophin is important in stabilizing the muscle, both in skeletal, cardiac, as well as in smooth muscle. So what happens in this condition is that this defect leads to chronic muscle fiber necrosis. The muscle degenerates and regenerates, and this manifests in some of the children as pseudohypertrophy of the cause. There is also this manifestation in the cardiac situation, leads to the cardiomyopathy in these kids. Becker's muscular dystrophy is a milder form of Duchenne muscular dystrophy, where there is a partial functioning of dystrophin, as opposed to the abnormal or absent dystrophin in Duchenne muscular dystrophy. So DMD, or Duchenne muscular dystrophy, is a progressive disease. The neonates appear normal. However, if you measure their CK levels, they are often elevated. There will be a positive family history. When you look at the milestones of the child, you find them, they are late walkers. They have difficulty in climbing stairs by age of 5, and very often by age of 6 or 7, they are wheelchair bound. The muscular weakness is progressive. It's on all skeletal muscle. This paraspinal weakness leads to progressive kyphoscoliosis. So very often you find these children present for scoliotic surgeries. The respiratory weakness causes decrease in vital capacity. And when you assess this child, you need to specifically focus on this. And you want to inquire about recurrent chest infection, about their exercise capacity. Very often, if they are already wheelchair bound, that's going to be difficult to evaluate. A pulmonary function test on blood gas becomes important. And especially if you have a pulmonary function test which are 30% below the normal level, you know that this patient stands a very high risk of requiring a ventilator support after the surgery. So you have to be prepared for those. Now that the muscle weakness extends even to the cardiac side. So these kids can present with the conduction deficits, dilated cardiomyopathy. And these dilated cardiomyopathy, and sometimes you find even in the carrier females also could have a dilated cardiomyopathy. So even though there is maybe an unaffected females, if they are carriers, they could present with dilated cardiomyopathy. And there is a subset of Duchenne muscular dystrophy who primarily present with cardiac problems. So you have to have this awareness that where even if the skeletal muscles are normal, if there is a positive family history of myopathy, you might need to specifically investigate for any cardiomyopathy in these patients. They could have gastric hypermotility, and gastric emptying could be delayed. And they could also have hypertrophy tongue. So they could have a difficult airway. So knowing the presentation as well as the pathophysiology you want to investigate, you want to, at least in the baseline, get an ECG where you might find a right ventricular strain pattern with the tall R waves, deep Q waves, and inverted T waves. The echo will show sometimes a ventricular systolic dysfunction, and it might progress to dilated cardiomyopathy. Sometimes you might just, all you see may be a resting tachycardia, and that may be an early sign of cardiac involvement. And some of these children, as part of the workup, do undergo cardiac MRI as well. As I mentioned before, a pulmonary function test and blood gases is important to have a baseline as well as have a plan of disposition after the surgery. You will find the CK levels are markedly elevated, probably in the orders of 50 to 300 times the normal. When you plan for the anesthesia, obviously when you think about anesthesia, we all think about the choices of your anesthetic agents you are going to administer. But equally more important is the baseline functional status of the child. So whatever technique you choose, you also need to temper it based on the functional status as well as the cardiorespiratory status of the child. Clearly, dexamethasone is contraindicated. There are many case reports where these children's single dose of sex ended up with rhabdomyolysis and hyperkalemic cardiac arrest. What has come interesting in the literature in the last 15-20 years is what you call anesthetic-induced rhabdomyolysis in patients with a DMD or Duchenne muscular dystrophy. What's happening in this situation is that the sarcolemma of these patients are prone on exposure to volatile anesthetic or to succinylcholine, breaks down and leaks potassium. There is no hypermetabolic situation, but it's more of a hyperkalemic situation. So it's not related to malignant hyperthermia, though you will find some of the constellations who sort of mirrors some of the things you see in malignant hyperthermia. Here, the primary problem is muscle breakdown, rhabdomyolysis, hyperkalemic cardiac arrest. This is increasingly recognized in the literature in the last 15, 20 years. And so people have moved from recommending not to use volatiles for these children and to total intravenous technique. You will see in the older literature, people undergone, patients with Duchenne have undergone scoliotic surgery. Even a largest case series published from our institute with half-max isoflurane in the past without any problems. So the theory is this, that when the children come for scoliotic surgery, by then they have, most of the muscles are burnt out, which means they don't generate the same hyperkalemic response. So whereas the younger children have enough muscle mass as well as muscle regeneration, regeneration, that they are the one who manifests this sort of a response on exposure to volatile. So these days, very often if we face a child with muscular dystrophy, we pretty much prepare, like for an MH, we don't need to bring an MH cart. However, you prepare the machine, take off the vaporizer, put a vapor clean filter, and run a total intravenous technique. So you would not induce them with a volatile. So you will try get an IV access if you sedate them. You can use nitrous oxide, not a problem. Get an awake or sedated IV and run a total intravenous technique. So I just want to go one slide back. As I said, besides talking about the anesthetic consideration, but also think about the other components of the disease. So we mentioned about the enlarged tongue. They could have contractures that might limit mouth opening. They could have a difficult airway. And because of the underlying clinical or subclinical cardiomyopathy, when they are subjected to major surgeries like a scoliosis surgery, they could have dramatic drop in blood pressure. So you have to be prepared to manage the cardiac if manifestation of this disease process when they are subjected to major surgery. We will use short-acting agents because they could be sensitive. Non-depolarizing muscle relaxant, they're going to be sensitive, so you want to use it in a titrated fashion with the neuromuscular monitoring. And very often these kids have to be monitored afterwards with both electrolytes and CK levels after the surgery, preferably in a high dependency unit or in the intensive care setting, especially after major surgery. Now, I'm just going to move on to a next set of myopathy, which has come about more and more in the last 10, 15 years, more understanding in the pathophysiology and genetic workup of these mitochondrial and metabolic myopathies. Before we go into the actual disease, let's going to revise some of our basic biochemistry knowledge about our Krebs cycle. We all know the mitochondria are responsible for the aerobic respiration and energy generation in the form of ATP by oxidative phosphorylation. And we know the electron moves through this electron transport chain through the complexes 1 to 5. At the end, an ADP is converted to ATP. That's how energy is synthesized. These complexes are under the control of both the nuclear coded DNA as well as mitochondrial DNA. One of the challenges with the mitochondrial DNA is that it is prone for very many genetic mutations. When you look at the genetic mutation on both the mitochondrial and nuclear coded on mutation of these complexes, there's probably around 50 to 100 of these disorders. So obviously it's difficult to understand the pathophysiology in each of these every condition. But in summary, these mitochondria are damaged because of this genetic mutation. they don't generate enough ATP. Not only that, in this process, there is an excessive generation of free radicals. Once the oxygen doesn't go through the Krebs cycle, it's going to take this alternative anaerobic pathway, which is going to generate lactic acidosis. So this leads to these free radicals leads to oxidation of the mitochondrial protein as well. And these mitochondrial proteins and these damaged proteins sometimes can be identified using histochemistry. And that's what it looks like under gomery trichrome staining. What you call the ragged appearance of these accumulated mitochondrial proteins under the cell membrane. So these are the reasons why some of these children are subjected to muscle biopsies, that they want to have the precise diagnosis that they can move on to what could be the treatment. So sometimes we don't have this diagnosis when the children come for anesthesia, and we have to think about what is the implication if this patient has a mitochondrial myopathy. When you look at the presentation, the incidence is probably in the similar order to DMD. It's probably in 1 in 4,000. And it has become increasingly recognized as a common cause of muscle weakness in children. The children can present in the neonatal period with profound weakness, liver and renal failure. They could have a neurological impairment. There's a term used when you read about mitochondrial myopathies called heteroplasmy, which means that not every organelle will have a similar distribution of the damaged mitochondria. So you will find certain organelles are more affected than some other organs. So this has led to the subset of conditions. Some of the common ones are MELAS, which is a mitochondrial encephalopathy and lactic acidosis. The second is a myoclonic epilepsy with the red fiber syndrome. That's the previous slide. I talked about accumulation of these mitochondrial protein under the muscle membrane, presenting as a red fibers. The organs which have a high oxygen uptake, especially your heart, your brain, and your kidneys, are the most commonly affected. When you think about the patients are usually a typical floppy infant, a poor feeder with small stitches. They have development delays, they're hypotonic. They may have a positive family history. Very often it's the de novo mutation, so you may not have a positive family history. And because it affects the entire cardiorespiratory systems in addition to other organs, a thorough workup of your heart and lungs are important. And very often you will find cardiomyopathy, conduction deficits, AV blocks, ventricular dilatations. These are not uncommon in children with mitochondrial myopathy. And they are very, very brittle patients. Any little stress, overnight fasting can lead to a deterioration of their functional status. So when you do the pre-op evaluation, you want to make sure they don't have any AV block because they might require pacing. You want to evaluate their baseline glucose, lactate, liver enzymes, and renal parameters. You want to avoid overnight fasting. You want to start an early IV access and provides a glucose-containing fluid, lactate-free fluid. Now, what type of anesthetic to give? When you look at the literature, most of the experts deviate towards if you know the diagnosis. If it's a mitochondrial myopathy, they will ask you to refrain from using propofol. Inhalation anesthetics are safer, but given that they could have an underlying cardiomyopathy and they could be very sensitive, you need to cut down the dose of your anesthetic. They could be sensitive to non-depolarizing muscle relaxant. And succinyl-CoA have on occasions have caused cardiac arrest in these children. So stay away from sucks. Most of this myopathy, you're going to stay away from these sucks. The question comes to whether you can use inhalation, whether we can, how safe is propofol, especially when the diagnosis is not certain. So we all know that propofol, component of propofol is a long chain fatty acid or sometimes medium chain fatty acid. And it appears to be a load on the mitochondria, which is already stressed, any of these fatty acid additions. And there may be a direct inhibition of propofol on some of these respiratory chain components as well, both in smaller doses as well as in high doses. So this picture depicts where propofol is shown to be an inhibitory in the mitochondrial respiratory chain enzymes. So what is now thought about is that use of propofol in children with mitochondrial myopathy leads to similar to what is called as a propofol infusion syndrome. You may recognize, you might have read about the propofol infusion syndrome that happens in both in children as well as occasionally in adults, where the high dose of propofol of more than 5 milligrams per kilo per hour for more than 48 hours used in patients who presented with sepsis, who are on high-dose inotropes, ended up having rhabdomyolysis and cardiac failure and severe metabolic acidosis. So it is now thought that children with mitochondrial dysfunction on exposure to propofol may develop something similar to a propofol infusion syndrome. And so that's a reason why there is a recommendation to avoid propofol. If you use propofol, use it in a lower dose and combine it with some original techniques and remifentanil or other opioids. Okay, now I'm moving on to talk about myotonias, which are an autosomal dominant inheritance disorder. The pathophysiology here is that there is a nucleotide triplet repeat sequence on the chromosome 19. This leads to delayed activation of your sodium channel, so the muscles don't relax. Again, this is there's a positive family history because of the autosomal dominant nature of it, and this is a multi-system disorder. You will find, again, like other muscle diseases, it affects the respiratory system with cardiomyopathies, mitral valve prolapse. The respiratory muscles could be sensitive. They could have intercostal muscle weakness, diaphragmatic weakness, bulbar weakness, and dysphagia is very, very common in these disorders. Some of these can present with like achalasia, and you might need to consider a modified rapid sequence because you might not be able to, you will not be able to use sucks in this situation. But however, they could have residual food content in the esophagus, which makes them high risk for aspiration pneumonia on induction of anesthesia. In terms of providing safe anesthetics in these myotonias, volatiles are safer. Because of the TMJ involvement, they could have a difficult airway. So you have to be prepared for that. And also need to consider about the post-op ventilation because they're going to be sensitive to any anesthetic or sedation. You want to minimize any myotonia that happens in perioperatively. So what are the triggers? Your triggers could be your pain. It could be a temperature change, your agitation. So you want to avoid sedatives. As you mentioned about a TMJ joint may make your direct laryngoscopy difficult. And non-depolarizing, once a myotonia sets in, the non-depolarizing will not be able to relax. So you have to have a backup plan of using any of these agents, such as unusual agents, such as procainamide or diphenyl hydantoin. Volatiles have been shown to relax in existing myotonia. As I mentioned, there is a high risk of perioperative aspiration and post-op respiratory complication. Manage their temperature and management of their pain, it becomes very important. The final muscle condition I want to talk about is the rhinodian receptor mediated mutation leading to malignant hyperthermia. Not all malignant children with malignant hyperthermia will have a positive RYR gene typing. And however, 60-70% of the kids who may have a RYR positive mutation. This condition is inherited in autosomal dominant trait. So any positive history of death in the family and exposure to anesthetic should inquire the possibility of malignant hyperthermia, and you had to refrain from volatiles as well as succinyl choline. The pathophysiology in this condition is that when you consider a normal depolarization that acts through the dihydropyridine receptor that is connected to a rhinodian receptor. This rhinodian receptor is the one that channelizes the calcium release from the sarcoplasmic reticulum, sarcoplasmic lumen, T tubules into the sarcoplasm, that is a muscle myoplasm. Okay, and when this rhinodian receptor is mutated, there is an uninhibited release of calcium from the lumen into the myoplasm, and this sets the hypermetabolic state. Now, understanding of this is important because this is where the dantrolene is going to work. The dantrolene inhibits this rhinodian receptor open state, as well as there is probably now increasing understanding is that there are other effects of dantrolene through other pathways as well. It decreases the calcium presence in the myoplasm to limit the hypothermic response you see in malignant hypothermia. So what's happening in malignant hypothermia is abnormalities in the intercellular calcium homeostasis. It causes the muscle rigidity and increased metabolism, rhabdomyolysis, hyperkalemia. What kills the patient is a hyperkalemic cardiac arrest, acidosis, and renal failure. So it rapidly progresses to death if untreated with the dantrolene. The inheritance range is probably in the order of 1 in 15,000 to 1 in 50,000. This is an occult myopathy. So children who present with malignant hyperthermia would be otherwise normal children who just on exposure to a volatile succinyl choline demonstrate this response. But there is a small set of myopathic patients who may have a malignant hypothermic response. The only association that has been proven are in children with central core disease, King-Denborough syndrome, and Evans myopathy. These are only 3 conditions where there is a clear association of a myopathy plus malignant hypothermia. All other myopathies may manifest more like an anesthesia-induced rhabdomyolysis response, but they don't need a treatment with the dantrolene. You would need to manage the hyperkalemic manifestation if you end up with that response, but they all don't need a dantrolene. Now, what are the agents that cause safe to use in MH susceptible patient and what is not safe? The safe ones are nitrous oxide, opioids. Your intravenous anesthetic agents are safer. Your non-depolarizing muscle laxants are safer, whereas the triggers are usually the volatile anesthetics and succinyl choline. I don't want to go into the details of, for the interest of time. I just want to mention this. Dr. Bhavya Dubey has extensively covered this in our recent symposium on crisis management. She did a fantastic presentation on it. So she has detailed all the presentation, immediate management, and post-crisis management in that. And I would refer to the listeners to refer to that talk to understand fully about how we manage malignant hyperthermic crisis. There are other channelopathies which can present in children. Some of them are like hyperkalemic and hyperkalemic periodic paralysis. Again, for the interest of time, I would refer, I would put up a link at the end of these lecture on some of these articles where you can get more information about these conditions. So I'm coming towards the end of this talk. From what we have understood is that a child with a malignant hyperthermia muscular dystrophy is safe to have in TVET technique. A child with a mitochondrial myopathy, we want to avoid propofol and vapors are safe. The dilemma comes when a child presents with minimal information, with no diagnosis, and you have to make an educated guess, especially if the child is presenting for an MRI as part of a diagnostic workup of their hypertonia, or person presents for a muscle biopsy, where the provisional diagnosis could be both Duchenne muscular dystrophy or mitochondrial myopathy. How do we make a choice of what anesthetic to give to this child? Obviously, we go through the history and evaluations and investigations, blood chemistry, to give some clues. What do you call the main useful ones are your CK levels, your lactate levels, and a family history and physical examination of the child. If your findings are towards muscular dystrophy, then you're going to avoid the inhalation anesthetic, and you're going to use tube. If the lactate levels are high, CK are normal, and there is an absent positive family history of any myopathy, you can guess that it's very likely mitochondrial. You want to avoid propofol, and you are safe to use an inhalation anesthetic. Sometimes you are conflicted, and what can I do an anesthetic where I can avoid both these things? Yes, you can. The literature is not very strong. It's still evolving. If you choose substitute your propofol with the ketamine and dexmedetomidine without an opioid infusion and avoid vapor, are you covering the basis? It seems to be, for me, it personally thinks it's a reasonable alternative, especially when if a muscle biopsy could be done, for example, with a caudal anesthetic or a spinal anesthetic, and all you need is a sedation to keep the child comfortable to this procedure. That is a very, very valid option. And I have used it in a couple of occasions for muscle biopsy, where preoperative midazolam IV placement, and I ran ketamine dexmedetomidine infusion and did a single shot caudal for the muscle biopsy. And I've used a combination again of ketamine dexmedetomidine for an MRI as well, where I could not ascertain what's the diagnosis with this kid, even after extensive consultation with a neurologist and workup. So to summarize, we considered some of the challenges and the necessary consideration in various myopathies. As I mentioned before, don't focus totally on the choice of anesthetics. It is the patient's presentation, pre-op history, and the cardiorespiratory status and functional status that's equally important, because you might give the perfect choice of anesthetic, but if you don't titrate it to the patient's need, you might still have a bad outcome with these. These patients are very fragile. They need a pre-op optimization, fluid and electrolyte correction, and you need to have a proper ventilator support, especially those with cardiorespiratory problems. So I've put in some QR codes as well as a couple of references. So people should be able to scan this from the computer to get to these articles of interest.
Yeah, nice
Thank you.
lectures. Wonderful. I think difficult topics, but I think very well covered. I think enjoyed it. Yeah. I think as you were talking about it, then I think we could actually have a postgraduate symposium where we actually just have those important topics as asked in exams. And myotonia is a common, at least for FRPA, myotonia is very commonly asked. Malignant hyperpyrexia is asked. Myopathies, other myopathies, myocardial, I think it's recently been.
Yeah, it is come up as a big
Yeah.
thing in the last,
Yeah,
I would say,
like-
5-10 years.
Yeah. So I think good, excellent. I think it's an excellent review of the topics. Anybody wants to add anything?
Extremely nice presentation, sir. Really enjoyed it. Just a word on dantrolene. It is not
Yeah.
very easily available.
Yeah, I didn't go into the MH too much because of this sort of.
I know. Sir
that-
had already covered in the crisis management.
We
Yes.
had covered in crisis
yes,
management,
yes.
and
Yeah.
I think in India, dantrolene is available, but it's actually at very few places.
Yes.
And
Yes.
I think it's sad. So that brings to the some of the doubts which are often asked, and there is recently a case, I think, in the our group, and in this case, I think the patient had ketamine and usual induction after that, and the surgery finished. The neuromuscular blockade was reversed, and patient back went very sort of catatonic, looks like. And they were wondering what would be the cause could be in that. So I don't know, because they had used everything. They used ketamine, propofol, volatiles. I don't think it is anything to do with any congenital myopathies or myotonias. Myotonias wouldn't be.
I think the baseline, I mean, it's very often, I think we have access to a blood gas machine. Any doubt I have, I just draw blood gas sample to check for both lactate level as well as look at any acidosis and potassium levels. That could give some clues if there is actual muscle breakdown and what they're worried about. Sometimes it may be just an emergence phenomenon. Very often we see in children just a regular emergence phenomenon. They might be a little rigid, and sometimes you need to resedate them. Very often,
That's what happened.
Half of our children we move with a syringe of propofol or a bit of fentanyl in our hands, right? I know they're going to be a little agitated as they wake up. Sometimes they need to sleep off. So it's not.
It's not.
I mean, awareness is important, but sometimes. That sometimes it's more to do with the exposure and experience of it, of the volume of cases you do. You see what is normal and what is an outlier, whether you need to investigate that. I mean, it's sometimes that is a challenge if you're not occasional pediatric anesthesiologist. If you find an unusual response, you always blame whether you're missed out on something.
Right.
But that could have been a normal phenomenon of an emergence of a child. So that's,
Yeah, I think that's what happened, and that person gave some propofol and everything was fine. I think that's what it is. Either emergence phenomena, or it could be like sometimes there is inadequate reversal, and people don't use neuromuscular monitoring, and they do it, and the kids become very it's there
Yeah.
shaky there. I mean, it happens in adults as well, and it takes some time for them to actually get over it, and they're fine. Yeah, I think you're right. I think that's problem is with people who do occasional pediatric cases, not seen those what you see in daily life with high volumes.
Yeah.
That's why like we were talking about, when there is a high volume centers, they see everything, so they're easy for them to understand. But where you're doing occasionally, you tend to start thinking of uncommon things first.
Yeah.
Chest wall rigidity with opioids is actually common. I have seen a few cases of that, and initially you really don't know what to do, but yes, it finally settles down.
And I think the other common question I think asked is about succinylcholine and what is it called? Jaw. Jaw locking. Jaw locking. Yeah.
Jaw clenching.
Yeah, jaw clenching, jaw locking, that kind of thing.
Locking, yes.
Yeah. So, what is your thoughts on that, Jody? I mean, we have seen. I've seen it in pediatrics when I was doing pediatrics. We didn't actually pay much attention.
There's going to be a spectrum of response. Some kids don't have it. Some kids have milder response of TMJ activation and difficulty insertion of laryngoscope. I haven't faced an extreme challenge where I could not insert, or if I time my sacs. I never introduced my laryngoscope before 45 seconds. Sometimes we are too hurried to insert our laryngoscope. Whether that signifies onset of or underlying malignant hyperthermia, or I'm still, though our institution is primarily and not a sacs user, I do have incorporated sacs in my regular day-to-day practice. I do use it, but again, because the volumes are going to be extremely small, it's difficult as a single physician, even in a bigger centers, to accumulate enough cases to say that this is a real rigidity as opposed to yearly introduction of laryngoscope. I haven't faced it. We don't even don't talk about it. Half of it maybe because we don't use sacs that often in our institute. But I don't know, Sanjay may have some more experience in that muscle rigidity on the use of sacs.
I mean, again, I don't remember when is the last time I used sacs for intubation. If at all I use sacs, it's mainly for laryngospasm and extubation. So given that experience, I haven't experienced much of rigidity with succinylcholine. No.
I think most places, I think with the is it atracurium used at 1 milligram per kg or 1.1 milligram per kg is as quick as I think succinylcholine in kids. So I think people have stopped using succinylcholine. At least I think at older age, that's what was practiced.
And several, I mean, a few large studies have shown that the risk of aspiration in children is extremely small compared to others. So I think this concept of rapid sequence induction is challenged in children. One is it can distort the view. People giving the laryngoscopy, I mean the cricoid, one is know the exact position, and children having short neck, they could press on the thyroid instead of the cricoid.
Yes.
So intubation becomes more difficult. And second is whether how effective it is to prevent aspiration. And the risk of aspiration per se in children is quite small. So now we've got a modified rapid sequence where we continue to ventilate the child with a visible chest rise, and so basically we don't use sacs for rapid sequence.
And even like with the atracurium, the you can intubate the kid within 60 seconds with very good intubating conditions. I mean, even in adults, I think I haven't used succinylcholine for a very long time. I mean, in emergencies, people are still using it, I think, but I think in a routine things, we don't use succinylcholine at all. But yeah, kids, I think it's common to actually with succinylcholine to see jaw getting clenched and people getting panicky about it.
Yeah, I don't know. I haven't faced it. I do use it. As I said, I do use sucks regularly. I haven't faced it. One of the challenges I find is that patients, when they switch from sucks to long-acting neuromuscular blockade, and especially when they cut down the dose of the neuromuscular blockade, for example, when we use the rocuronium, the recommended dose for a rapid sequence is 1.2 milligram per kilo. That will give a early onset. But if you cut down to 0.8 milligram, I'm not giving, but you're still expecting at 45 seconds the patient to be fully relaxed. So you are now you have an unrelaxed patient, and obviously any partial reflex response can cause regurgitation. And now, especially in a full stomach patient, especially the typical example I give is a child with a pyloric stenosis. It is never an empty stomach, even if the patient had an NG in place. And if you don't give your rocuronium enough time to work, and as Sanjay mentioned, if I said choose your agent, but give the adequate time for it to work. If you give 1.2, 45 seconds is fine. If you do 1, I just hand ventilate gently for at least a minute and 10 seconds or so. If you do 0.8, give 2 minutes, gentle hand ventilation. Keep your oxygenation going before you introduce a laryngoscope. If you introduce a laryngoscope yearly in a partially relaxed patient, then the patients can reflex, regurgitate. Now the oropharynx is filled with the curdled milk on a 1-month-old child who you haven't, the number of time you've intubated 1 month old may be very small, especially with the trainees. So now you have a difficult airway in front of you with a risk of aspiration or already aspirating. So I think I do insist on giving enough onset time for the muscle relaxant to work. I don't really worry about whether you choose sucks or non-depolarizer, but insist on the time so that when you introduce a laryngoscope, the patient is fully relaxed, anesthetized, and oxygenated. All those 3 things.
So I have a question for everybody. So if everyone uses muscle relaxants in all the pediatric patients when you're intubating?
Especially if it is an abdominal surgery and emergency surgery wherein laparotomy and all, yes, definitely. But otherwise, for if you're inserting an LMA and giving a regional block.
LMA, I'm talking about the ET tube.
Sir, earlier we used to do just give 1 dose probably at the time of intubation, and then if it is a short procedure, just get away with it. No more additional doses required. That I have done.
Do you mean, Vikram, that I think in kids you can have good intubation condition with just sevoflurane? Is that what you hinting at?
Yeah, I mean, over here, some of the people don't use muscle relaxants. I'm not used to this and I don't do it. So I intubate with muscle relaxant in almost all the cases, except some of the conditions. But as such, routinely, I do use when I'm intubating. But here, people do with propofol or, sevoflurane, depending on how it is.
Yeah.
In cardiac, sir?
Not cardiac, I'm talking about general.
General,
we had a case of myotonia congenita last 10 days ago. This child was 9 months old, weighing 5 kilos, came for endoscopic peg insertion. So obviously I've not seen this condition, so I read about the literature, and it says avoid volatiles, avoid sucks, but you can give non-depolarizing. But I tried to intubate this child with propofol without the muscle relaxant, propofol, fentanyl, ketamine. Okay, could intubate, but once the endoscopist started doing the endoscopy, the child started coughing. So I didn't want to sort of dose the child with too much propofol, so I had to paralyze the child. I gave a small dose of muscle relaxant, and then not well actually. So that's a recent experience.
So in endoscopy, we use remifentanil. I mean, so bolus of infusion.
It's not available in India.
Remifentanil is not there in India.
We don't have
What is your experience regarding use of Dexmed in these situations?
again,
Like if you want to avoid muscle relaxants.
yeah, PEG is a very small procedure. Yeah, so we wanted the child to be awake as quick as possible. It takes only 10 minutes per PEG. So the endoscopist inserts it from the top end. The surgeon makes a small incision and they do it endoscopic guided. So within 10 minutes, the child will be out. Yeah, so Dexmed.
Dexmedetomidine, ketamine. Dexmedetomidine and ketamine mixtures are
could be a choice.
provide both sedation, analgesia.
Yes.
I think that and short duration. I think those are.
So
Sanjay, there is no contraindication to volatiles in myotonia. If you have a diagnosis of myotonia, you can definitely use volatile anesthetic. It's a muscular dystrophy children.
Yeah, after the lecture, you said that it can be used, but again, there are 1 or 2 articles mentioning not to use. So to be on the safer side, I didn't want to use it.
Myotonic patients can be extremely sensitive. I mean, you need titration. You have to be careful. I still remember one of the most challenging adult patient I ever done was a myotonia patient coming for urgent laparotomy. Airway could be difficult because of the contractures. They have a high risk of achalasia is a common problem. They can have a high risk of aspiration. Your technique of intubating with I would probably, given the complexity of the child, so some of my principles are that if the child is extremely complex, I paralyze. To answer some of the Vikram's question, if the child is complex, I sometimes use paralysis to my advantage. I said that use a small dose of muscle relaxant so that I don't want to play with propofol or remifentanil, this and that, so that use muscle relaxant and reverse at the end. We do less than 2 years of age. If your muscle relaxant indication is just to get the tube in place, we can do it with just propofol or deep SIBO. Both are equally good options. But if the child is, like full stomach, and then you probably do use a muscle relaxant. Very often we like a nasal intubation for dental procedures. We use remifentanil a lot for those procedures for intubation. Nasal intubation, we just use 2 to 3 mics per kilo of remifentanil. That works beautifully for so non-paralysis intubation options include propofol or remifentanil or deep SIBO. Yes. To Vikram's question, you can. Many people do place endotracheal tube without using muscle relaxant. But obviously, you want to choose your patients. What is, what? If I have a trainee, very often I use a muscle relaxant. If I'm doing on my own, I might do without a muscle relaxant. You want to give them the best intubating conditions for them, so that you want to separate the experience versus muscle relaxation. Because remifentanil, like it is not as good as a muscle relaxant, right? So it's going to be, you might be able to pass the tube. As soon as the tube goes in, then they start to cough. So you might need to deepen some additional propofol. For your case, I think when the surgeon, what you could have done, I probably would have gone with a small dose of muscle relaxant from the get-go, atracurium or vecuronium. I don't know what's available in India.
Both are available.
You have rocuronium now, is it right?
Yes.
Yeah. Yeah. Obviously, it means that you need to monitor the neuromuscular function afterwards to ensure that the good recovery. Yes, I have faced the similar. What exactly you remember? Like you're able to place the tube, but as soon as they start, especially if you're doing an endoscopy and upper endoscopy in a child with eosinophilic esophagitis, they're extremely sensitive. So we may be running like we would have given the intubating dose of propofol and running an infusion of propofol. We do those cases, many cases without an endotracheal tube on IV propofol infusion, spontaneous breathing. But those are the conditions where I would even use a 1 microkilo of fentanyl in addition to this, so that to smoothen the insertion of endoscopy, especially when they pass the cricopharynges, they can be extremely stimulating, and those esophagitis can be extremely challenging to keep them adequately anesthetized without paralysis sometimes. Yeah.
JD, thanks very much. I mean, your lecture was really nice. Did learn a lot of points. Just one thing, is it fair to say that when you have a suspected myopathy patient or a hypertonia patient, one thing is, would a combination of ketamine, dexmedetomidine, fentanyl, and maybe half the dose of non-depolarizing, will it work for all conditions which you mentioned?
Why do you want?
So ketamine, dex, fentanyl, and half the dose of non-depolarizing. Would you say?
Why do you want to mix fentanyl, Sanjay, with dexmedetomidine and ketamine? What advantage would it have? I mean, looking at analgesia, you're going to get analgesia from both dexmedetomidine and ketamine. So I don't know what is the role of mixing it with fentanyl as well. Dexmedetomidine and ketamine will do, I think, most of the job.
And yeah, I mean, those choices you mentioned are really good. I mean, that's what. So the literature yet is come out with this sort of a recommendation or the guidelines from experts. They are still exploring whether we could shelve this whole dilemma. The hypotonic dilemma has been there for 15-20 years, swinging between what is propofol is safe or vapor is safe and sort of thing. Yet they haven't come out when saying that, okay, let's shelve both these two drugs. Let's do ketamine dexmed combinations and use that as a primary anesthetic. I think that's a very reasonable option. As I said, I've done some of the muscle biopsies with this sort of a dexmed, spontaneous breathing, turn the child on the side and do a single shot caudal, because they usually take the biopsy from the lateral thigh. That seems to be a workable solution, and same combination work for MRI as well. But I'm not sure I can run a 1 hour, because here our scans are usually an hour to 2 hours of MRI scans, and we run propofol infusions. And some of these kids are very fragile, and they may not be able to tolerate this amount of propofol, this 1 or 2 hours of propofol. We don't know the outcome of it. You don't want a kid who is already compromised end up with a metabolic failure and ICU admission. And there is very many literature. In fact, and I think Anshuman is one of the senior from IE, works in St. Louis, Missouri, I think.
No, he's moved to Washington, I think now recently.
Washington. So he did an editorial actually on this hypotonia, which I think I put it on the references. He also talks about this, the risk of how fragile these mitochondrial children can be, and even this single smaller dose, we think, 4 milligram per kilo should be safe, but we don't know. On a given child, this particular child he talks about passed away after 10 days in ICU after one exposure to propofol. It's not to criticize, because sometimes we don't have the answers in front of us to give that right anesthetic for these children. So you have to sometimes, however explanation you give to the parents is not enough. It's like the child is passed away, and you always wonder, like, what could I have done differently? And you might have used the best resources available to you at that time to make the judgment. And sometimes you might need to do it safely, as you mentioned, whether I should just do with the ketamine dex and without the opioid. And that seems to be a reasonable combination. And small dose of non-muscle relaxant to help to get through some of these stimulating parties is necessary. That is very safe, I think.
So we do routinely get these kind of patients with some hypotonia and some muscle weakness coming for MRI, which lasts around 2 to 3 hours.
Correct.
Cardiac MRIs.
No, not cardiac MRIs. I do general.
Okay.
So, yeah, so
regular MRIs.
Some muscle weakness with hypotonia and not central weakness, but yeah. So these last for 2-3 hours. So what would your suggestion be? How do we go about
You could run a ketamine 2 per kilo per hour plus Dexmed at a rate of 1 mic per kilo bolus followed by 1 mic per kilo per hour infusion. So you could run this as an infusion for this kid. Obviously, you need to monitor them. We don't know the outcome of prolonged ketamine infusion on these kids. You want to monitor the metabolic status, CK and electrolytes, provide sugar without lactate-containing fluid. So metabolic maintenance, cardiorespiratory stability becomes paramount longer the procedure is, rather than the choice of anesthetic in itself.
Interesting.
Yeah, cardiac MRI, they also once
what do you
stop
do
the breathing.
what-
Like very often when I go to the cardiac MRI unit and they said, oh, we want to stop the breathing, you know, like, well, 99% of MRI we do with profile infusion, nasal prongs and spontaneous ventilation. Now we have to put in an LMA or use some endotracheal tube and control the ventilation. So it becomes a little challenge, especially with cardiac MRIs.
MRIs, they want their patients to be completely still, isn't it?
Yeah.
ECG, so they want apnea, like it keeps on going. So.
For hours together.
Yeah.
The worst thing is the patient will be completely asleep, but will be head bobbing. I don't know whether you guys faced it. The kid goes up to sleep with the crying. They continues to cry even they sleep. And that little movement of the head. And I twice I would paralyze the kid and put an LMA just for that.
Yeah, it's happened many times.
Yeah.
Okay, guys, before we end, there is one question about breaches. So this is Robin Dahl. He's actually said that he had a patient around 24 kgs, and he actually had given 20 mics of fentanyl, and and he couldn't ventilate the patient, like wooden chest. Would you actually expect this kind of thing with such a small dose? I mean, it's about less than 1 microgram per kg of fentanyl. You don't see in that small doses, do you?
Shiv,
It's only seen with higher doses of fentanyl.
Shiv, what I have observed is in some children, particularly if they have a propensity for airway hyperreactivity, a recent URI or a present URI.
Okay.
If you inject 3 drugs very fast, one is propofol, second is fentanyl, third is atracurium. If you inject one of them very quickly, sometimes they will just go in for a spasm or they will breath hold. I've seen that on a regular basis. I don't know what others feel, but if you inject them very quickly, they can go for laryngeal spasm or breath holding.
I think that was, the case here. I think as far as I actually understand, because I then gave succinylcholine 0.1 milligram per kg and everything went fine. So it looks like the vocal cord just went and they couldn't ventilate. They thought it was a rigid chest. So it is very unusual. So this reminds me actually of a case where one of our anesthetists actually was using remifentanil, and instead of going on the remifentanil, the protocol, he actually put the patient on the propofol protocol. So the patient ended up getting a huge bolus, and they couldn't ventilate the patient. There is, when you get TCI, Minto model and those kind of things, he went on a propofol. So it ended up actually giving a much larger bolus. So it's, but luckily with the remifentanil, that it will, within 3
go away soon.
Absolutely, as soon as you stop. So they realize that. But with fentanyl, I think you need a much higher dose, 5 to 10 milligram per kg, to get that.
We routinely use fentanyl 1 to 2 mics per kilo on spontaneous breathing. 1 mic per kilo definitely on spontaneous breathing children. When I do endoscopies, I never had a set of a rigid chest with that. I think, like Sanjay said, it's probably either inadequate depth or rapid succession of medications. Sometimes you find that children do cough when you rapidly give fentanyl bolus. So it's probably one of those events rather than muscle rigidity is secondary to remifentanil. We on pediatric recommendations are usually 2 to 3 mics per kilo. Even that, I would usually give it over 20 to 30 seconds, not push it as like a quick bolus. You still want to do it slowly. Very often you don't need to pre-treat with any atropine or black parlate. Even at 2 to 3 mics per kilo, you can still do it safely as long as you give it slowly. You can avoid this. Good depth is important, and not to rely on a good dose of propofol is important. And when we do lumbar puncture, we realize that some of the children, especially on repeated exposure, can develop some degree of tolerance. Can't explain, there's no biochemical explanation for tolerance to single dose propofol administrations, but you do see that they tolerate. I have done like 6 to 8 milligram per kilo of propofol for like a 5 minutes lumbar puncture, because the kid either moves so much, it's still reacting to the stimulus of the needle and arching its back out, and you want to do it safely, so you might end up giving a lot more. So they do tolerate a lot more propofol, and the requirement is at least a 3 to 4 milligram per kilo. We just need to recognize that children do need a higher dose of propofol. Okay, I think it's getting late there, and you guys should go and get some dinner, and I should go and get some breakfast. I think we should. It is wonderful. Thanks, Shiv, for giving us a platform again. Vikram and Uma and Sanjay, thanks for joining.
Thank you, sir. Thank you so much.
Lively as always. Vikram, you should give me some couple of dates for the cardiac. It